Thank you very much. My job's to round up. You'll be glad to know I don't have one radiographic image in my presentation. Nor do you really want to hear what I got up to at the European Stroke Congress. So I've changed the title just to thing it. And what I wanted to do, just drawing this to a close, is to just pose some of the pragmatic problems that we may have with introducing this treatment. And basically, we're all pretty unsure, aren't we, where we should be using these techniques. What we mustn't forget is that we're essentially talking about patients who have, for the most part, very severe strokes, relatively poor outcomes, and patients where we know that IV thrombolysis, even if given relatively early, is relatively less effective. And you've only got to go back to the National Audit Office report from 2005, which kicked off the National Stroke Strategy, which was, if you remember, the first time that anybody in the Department of Health sat up and took any notice about the sort of costs of stroke care. So we know that in total we're probably getting through £8 billion, well probably more, that was in 2005, wasn't it? So it was £8 billion for England and Wales, the cost of stroke care. And a very substantial chunk of that is the social care costs of looking after people with major disability. One of the challenges we've got is we're not talking here about a cheap intervention. I haven't gone into the costs of it, but we've got just getting the infrastructure together appears superficially more expensive than standard stroke care, just putting somebody on the ward. However, if you take the average cost of looking after a severely disabled patient in a nursing home as around £50,000 a year, you don't actually have to save many of those to make even really quite expensive interventions cost effective. But nevertheless, this is a case that we're going to have to make, particularly in constrained financial times such as we appear to have now. Now, your heart, if you like, tells you that this is the right way to go. And that's partly because we've followed the cardiologist, haven't we? We've followed the cardiologist with IV aspirin to start with. We then followed them with IV thrombolysis. And of course, you look where they're at now with primary PCI. Yes, they're dealing with a much simpler organ, not half as complex. They don't need to be as cerebral about thinking about their patients. They just go in and stick the devices in. But nonetheless, we know that those interventions have transformed coronary care. And on first principles, if applied to the right groups, your heart tells you that those principles are going to work for stroke patients. Nonetheless, it's going to be more difficult to prove it. And although the previous speakers have been saying, yes, look at the numbers in these trials or in these series, if you showed those numbers to the cardiology conference, they'd just laugh in your face. Compared to the multi-thousand patient trials that cardiologists are able to amass very quickly. Now, that's not to knock things like the Stroke Research Network, and that's been a big change. But actually doing the trials that will be necessary for this is going to be a real challenge, I think. And one of the challenges we've got is that any of us who've been close to this sort of intervention will have all seen these Lazarus-like patients where your gut tells you that they're going to do incredibly badly, but they come out having had the clot removed and walk out a couple of days later. We've all seen them, but all I would ask is that we've got to keep it in perspective. There's no good people saying, yes, I believe it works, I'm therefore not going to participate in clinical trials. Because if you start coming at it from that point of view, we will never persuade funding on a national basis to develop the sort of services to give equality of access to all patients. At the moment, there's a huge, or I presume around the country, there's a huge sort of postcode lottery going on, depending on whether you happen to live nearer to somewhere with an interventional neuroradiology setup. And we know that if this is going to be a treatment that's going to be rolled out, then we've got to sort out referral mechanisms to give equity of access to all patients. And that's one of the challenges, and I suppose I'm talking more parochially here to the people from West Yorkshire, but this is one of the things that the clinical networks are going to have to sort out. But it's not easy to sort out something in an evolutionary phase when funding streams don't necessarily follow it. So that's just one of the challenges we're going to have. I like this slide. I like the thing. The context is important. Christine mentioned it. I mean, there's a bit of duplication with Christine, but just to finish off, it's when you start to try and look at the literature on these things, you've got to keep the context of the trials in mind because they are very, very variable. So it's been tested as a planned adjunct to IV RTPA. Now, in many ways, that seems to be, this is the area that the PEACE trial is interested in. So we, as the stroke clinicians, need to be making sure that our services get slicker and slicker and their patients are getting the IV TPA straight away. Because whichever trial you let, I mean, all right, one or two German centres may make it into the cath lab with groin time in 20 minutes. But by and large, everybody else is saying, if you can get it in under 90 minutes, you're doing very well. So there's an inherent delay coming in from the intra-arterial approach. So doing it as a planned adjunct to IV TPA must, to my mind, be the most logical place to explore. Yes, there are these other ones, often in hospital strokes, where IV TPA is contraindicated. Fully understand that. Christine showed you a couple of good outcomes from that. I think it was Ahmed who was saying, this as rescue therapy when you fail to recanalize an artery and it's late and things like that, I begin to be a little, I think it's a bit questionable. However, different trials have got different inclusion criteria, we've got different patterns of arterial occlusion. Christine showed you the different recanalization rates with IV TPA depending on where the arterial occlusion is. We've got this idea promulgated by predominantly West Coast American radiologists about the value of diffusion-perfusion mismatch. You only have to go north of the border here and you'll find somebody like who would poo-poo the whole concept of, I think, of diffusion-perfusion mismatch as a likely way of selecting patients. And as Tufel was saying, there is this huge range of devices, and actually it's rather different to doing drug trials. The stroke clinicians are quite used to doing drug trials. This is really the first of the device trials perhaps you've been involved in, unless you've been involved in carotid stenting trials. And the problem of leapfrogging technology and how you incorporate that into clinical trials is really quite challenging because devices change much more quickly than drugs do. They evolve, I mean, whereas a drug comes to the market. So and NIHR have recognised that how you assess these medical devices is actually quite a challenge. I don't know that there's a good necessarily a good explanation or a good way of doing it. What we do know, that the two sort of take-home messages, of which I think we can probably all be reasonably certain, is that you get better outcomes are generally associated with shorter time to treatment. So the take-home message is still get your services slicker, slicker and slicker. And by and large, successful recanalization. Not always, because I think, as you were just beginning to get, late recanalization can be absolutely futile. But if we're talking about early treatment, then recanalization is the goal, just as it was in the trials of cardiac treatment. And I put this up just to show you that there are differences by device, and some companies are willing to have their products put up head to head, but there are very few of them. But you can see, I mean, you probably can't see them, but there was a trial called the SWIFT trial where the Solitaire device, the Covidien Solitaire device, was put up against the Mercy Retriever device, and you've got recanalization rates difference between 89 and 67%. So there are data out there to show that devices in head-to-head double-blinded randomized trials are different. So this is not just a marketing ploy, shall we put it that way. There does appear to have been genuine improvement. So we've got to bear that in mind. So coming back to what I was supposed to be talking about, which is what happened at the European Stroke Congress, a lot of the interest was around this IMS3 trial. And you can't see it. You need to go back to the paper in the New England Journal where it was published. The trial was actually stopped on the grounds of futility, and but it used a whole range of devices. And in fact, I went back to the paper this afternoon and tried to work out what proportion of each device was used. And as far as I can see, they don't actually state it in the paper, do they?
There's very few solitaires.
I know there are very, I guess I knew you were going to say that. There are very few solitaires. But it's very, very difficult to get that key piece of information from the New England Journal of Medicine thing. Now, the only reason, I'm not going to go into the IMS results, except it was then very interesting how these results were picked up by, this is an NIH-funded study, predominantly in America. In North America. And it was then very interesting how the funding organisations responded to it, because it was essentially, well, or some of them took the view that that is the end of thrombectomy. And it led to Joe Broderick, who had run the IMS3 trial, being asked to write an editorial in Stroke about this whole issue of reimbursement for thrombectomy devices. Now, you may say, well, why are we worried about how American healthcare or health maintenance organisations reimburse thrombectomy? But in a way, the argument is not dissimilar to us. And the issue that Joe Broderick, one of the points Joe Broderick made was that, yeah, okay, this was one trial that failed. But there are all sorts of limitations to the trial. It's funny subgroups. It's technology had moved on. But it opened up a debate in the States about how you fund services that are required to underpin doing the studies that you require to show whether something is worthwhile or not. It is not like a standard drug trial, which has very little infrastructure cost behind it. These device intervention trials have an infrastructural cost that somehow has to be in place before you can even consider doing the trial. And that is a real challenge. It's a challenge. It was a challenge in America. It's an equal challenge, but from a different point of view within the NHS. Now, PEAST, which is I think I might even come to that. The NICE came out. You can all read the NICE guidance. The NICE guidance really does say very strongly that if you've got somebody who's fit for IV thrombolysis and you want to have thrombectomy as an adjunct, they really should be considered for the PEAST trial, which is the pragmatic ischemic stroke thrombectomy evaluation. So this is a UK trial. I think we're technically in a pilot phase, aren't we? I think that's how it's described, funded by the Stroke Association. Because of NIHR funding, the cost of this actually can be recouped by the places doing it. Now that's okay, except you've still got to have the service there to recoup. So one of the discussions we need to have, it'll be interesting to hear how Christine's going to approach this in Stoke, but one of the interesting things will be how we set up a process to think about getting appropriate patients to, in the case of West Yorkshire, to Tufale and Toney, and then, depending on the volume, how the hell the LGI copes with these sort of things at a time when you're trying to squeeze a major trauma centre into the same building. So there are challenges, but the take-home message has got to be, we must do the trial. This is a good trial. It's learnt the lessons. There are really tight criteria for how quickly we treat people, and that's how quickly the IV thrombolysis is given and how quickly the intervention is done after the IV thrombolysis. So in other words, the PEACE trial, although pragmatic, has learnt the lessons of the earlier trials, and we need to do it if we're going to, if we intrinsically believe that this sort of intervention is going to, in the end, it's going to benefit a subset of stroke patients. It's not like quite doing every STEMI, but it will, I believe it will benefit a subgroup. Whether I know exactly what that subgroup is at the moment, no, I don't. But we're in the early days. But somehow we've got to bring everybody together to make sure that people do get randomised in primarily PEACE and the trials that will inevitably follow to get the best out of it and to reduce what can be very serious morbidity and mortality for our patients. So I think I'll leave it at that and then open the floor up to the panel discussion. Right.